welcome. My name's Julian Savalescu. So we've got a meeting going on at the centre until 5 p.m. So some more people will filter in. But welcome to this special double seminar, Ethical AI in Healthcare. It's a great pleasure to welcome our two international speakers, both world experts in this area. The first speaker will be Boris Babic from Toronto, but now also Hong Kong. He's a barrister who's also done a doctorate in this area. It's published with Cohen from Harvard. And he'll be giving the first talk for sort of around 25 minutes, and then we'll have about 20 minutes of questions. And then we'll move on to the second speaker, who is Abhishek Mishra, who is a graduate from Singapore, did I think a master's and an undergraduate degree in the philosophy department here, and has been doing a PhD or DPhil with me in Oxford over the last few years, and is also working now for the UK government or related to the UK government in AI. So without further ado, we might get Boris to kick off, and sorry if there's sort of some late arrivals, and so over to you.
Thank you, Julian, and thank you all for being here. Happy to be giving this talk today. Okay. So this will be kind of a deepish dive into a niche-ish area at a kind of still very like draft level. But so the title of the talk is Managing Failure: How Should We Track and Govern Problems Arising from Medical AI/ML Devices? So here's what we had in mind for this project. We wanted to look at how the FDA adverse event reporting and recall system has been applied to medical devices that have been legally marketed in the US that have artificial intelligence or machine learning functions in particular. So it's not like we had a specific kind of like argument ex ante. Part of it was just like, let's look at the FDA's data and see how this system has worked so far. But some conjectures were that adverse event reporting and recalls would not be particularly effective at identifying problems associated with artificial intelligence or machine learning medical devices, because the kinds of problems that tend to occur are not well suited to such an infrastructure. They tend to be small scale problems that only make sense when you kind of look at them at an aggregated level. Whereas the adverse event reporting and recall system is really kind of patient-centered, like a situation where kind of concrete medical device, like a heart stent or something, fails and someone might die like ASAP if something's not done. And that tends not to be the kind of problems that arise in the context of AI/ML devices. But it's still very much an early work in progress, so I would just walk you through where we are so far. And I have some kind of like open-ended questions, the sort of things that I'm curious about to hear from the audience as well. Okay. So my co-authors on this project are Cohen from Harvard Law School and Ariel Dora from Harvard Business School. Glenn works in bioethics and Ariel works in healthcare economics. And we also have two really great RAs, Ivan Lee and Melissa Oulet, who have helped us with a lot of the data analysis. Okay, so here's the plan for this talk. I have kind of three parts. I'll walk through the regulatory background. So this is in particular the FDA adverse event reporting and recall system. Then I'll introduce you to the data that we've been working with and kind of like a few things that are sort of interesting that we found through it. This is the FDA's 510K database, sorted to include AI/ML devices in particular and merged with the adverse event reporting database. And then I'll talk a little bit about the limits of adverse event reporting, which is what I promised, and consider what can we do instead that would be more effective. Assuming I am or we are right that this isn't the most effective approach for identifying problems with AI/ML devices. Okay, so step one, the regulatory background. In the US, the modern medical device regulation began with the 1976 Medical Device Amendments to the Federal Food, Drug, and Cosmetics Act, the FDCA. This is the governing statute. The MDA contains a tiered risk system for medical device approvals. So medical devices cleared by the FDA or legally marketed are kind of class 1, class 2, or class 3 devices. Class 1 devices are kind of like very low risk. This is like wellness apps or something, like nutrition tracking. They have almost like no regulation. Class 2 devices are kind of like mid-risk. Usually they're approved through a process whereby a predicate device that is substantially similar and already exists in the market is identified. And class 3 devices are the highest risk and most invasive devices, and they typically require clinical trials. Most medical AI/ML devices have been cleared by the FDA under the class 2 risk structure. In this project, we focus in particular on post-market surveillance of legally marketed medical devices. So that's why I jumped through all this like class risk tiered system stuff pretty quickly, because we're going to be focusing on devices that are already on the market, because those are the ones for which we have adverse event reports or recalls. So we're kind of already assuming they've been approved under one of these pathways. So far I've been using the disjunction of adverse event reports or recalls. We're actually going to focus on adverse event reports specifically. The reason for this is that there's just not enough data on recalls. So the first medical AI/ML devices have been approved around 2016. In all of the data that we pulled up, there was like 8 or 9 recalls. So there's really no particular patterns that we can identify that looked interesting. So we focused on adverse event reports, which are a lower bar, and at least there was, I think, like a couple hundred of them. Okay. The FDA adverse reporting system in particular, so this is the structure. Medical device reporting is one of the central post-market surveillance tools for managing medical device related adverse events. Sorry. The core reporting requirements are laid out in the MDCA and have existed in their current form since 1995. The MDR requires manufacturers, user facilities, there's like hospitals, and importers of legally marketed medical devices to submit reports of certain adverse events. We're going to focus on manufacturers in particular. Importers is a little bit of a niche category, and for user facilities, many adverse events reports end up being voluntary. So kind of like the core of what we're interested in is how are manufacturers of products identifying problems with their products. The FDA refers to these as MDR reportable events. MDR reportable events for device manufacturers include reports of death, serious injury, or device malfunction. And a malfunction is reportable only if it would be likely to cause death or serious injury. Some of these legal requirements, I feel like they're worth stating up front. I'll revisit these once we look at the data and some of the problems that I think exist with the system, because most medical AI/ML devices tend to cause problems that do not rise to the level of causing death or serious injury. It doesn't mean they're not worth tracking, but already the structure of the system is such that you're less likely to identify things that would be of interest as problems when it comes to AI/ML devices. There are 2 types of reportable events, so-called 30-day and 5-day reports. 30-day reports are standard. 5-day reports are generally only required when a reportable event requires immediate remedial action to prevent substantial harm to public health. Any of the following can be a factor in an MDR reportable event. It can be a failure, malfunction, improper inadequate design, manufacturing problem, or a labeling or user error. So one could have an adverse reporting event that's mandatory without a malfunction, although most of the focus is on malfunctions, but it could just be user error. And sometimes with these reports, we don't actually know which is which. It's hard to identify what the source of the problem is from just reading through them individually. So this is a kind of brief flowchart of what I went through. We have importers, manufacturers, device user facilities. They report to the FDA. things like death or serious injury, particularly malfunctions. And I'll be focusing on really the main branch manufacturers to the FDA. Okay, so that's a really quick run through of the regulatory background, step one. So then step two is the data that we've been looking at, and here's what it is. So I mentioned earlier, most of these AML devices have been cleared under the moderate risk class 2 category. These are regulated through a process called pre-market notification, or more often the 510K process. This requires a device to demonstrate substantial equivalence with one or more already legally marketed devices. Class 2 devices that don't have a predicate device can use a de novo classification request. The good thing is the FDA maintains a comprehensive 510K database. As the basis for our analysis, we downloaded first we downloaded the full 510K database for 2010 through 2022. We then filtered this for the 8 largest medical specialties, just so the numbers are not overwhelming. We further filtered this for devices with a software component. And then finally, we isolated only those software devices with an AI/ML feature. The final result is a total of 300 devices. Now, one thing about this, so there is a kind of legally recognizable category that the FDA uses, which is called software as a medical device, or SAM. But AI/ML devices, even though I've been kind of like repeatedly using this expression since the start of the talk, they're not like a legally recognized distinction or anything like that. So to identify AI/ML devices within the list of all SAM devices, we just try to look for keywords that would suggest that the device is using some sort, or claiming to use some sort of artificial intelligence or machine learning component. This is like far from a perfect exercise because, first of all, there are so many companies that are using the keywords like jargon. Oh, we're using artificial intelligence, but it's not clear how. So we can be catching things that aren't actually AI/ML devices, and we might also be missing things that really are AI/ML devices because they're not using some of the keywords that we thought to use in the search and filtering process. But it's not like do or die for this project. We're just trying to make the data manageable. So we have a list of 300 devices, and this list is inevitably a little bit over and under inclusive. The 510K database includes information on the device type, device manufacturer, dates, and medical specialties associated with the device. So step one. Step two, we merge this database with data on adverse events associated with medical devices as collected by the FDA elsewhere in the medical device adverse event reporting database, the MAUDE database. So what we end up with is this 510K database merged with a MAUDE database so that we can identify product codes to adverse event reports. This leads to a final set of 510K cleared AI/ML medical devices and their associated adverse event reports. This is a picture of what I've been talking about. So we got the full sample. It had like 38,000 product codes. Then we filtered it down to top 8 medical specialties. That was like 30,000, limit to devices with readable regulatory documents so that we can search through them, and then identify those that are flagged as including software or SAM, and then among those, flag the ones that include some AI keywords. And so that's what leads to the 300 devices that we ultimately end up with. When I said we use the top 8 specialties, kind of like the most common, not sort of top, but most common specialties, these are the ones. So clinical chemistry, cardiovascular, dental, gastroenterology, general hospital and personal use, orthopedic and rehab, radiology, and general and plastic surgery. This is using FDA's categories. In terms of where the devices are coming from, unsurprisingly, most are from the United States. Other kind of popular destinations for manufacturers, Israel, Japan, France, and China for the top 5. I mean, these are devices marketed in the United States. Okay. So some things we try to identify from the data. Number of reported events per year. There's really no devices, like I said, before 2016. And then we see a big increase of adverse event reports, which kind of tapers off, I suspect, basically like during this being like COVID period. And then we don't have the 2023 to see how that looks this year. But that's the distribution of adverse event reports across AML medical devices over the last 5 years. The time to report, almost all of these reports are the 30-day reports. Some are the 5-day reports. Others are coming in late or are voluntary, but they all have to be 5-day or 30. They're supposed to be 5-day or 30-day. Number of reported events per product. So this is a count per product code. Actually, we ended up with, so there's only like 11 product codes that have some adverse event reports out of the 303 devices. And of those 11 product codes that have some adverse event reports, as you can see, almost all of them are coming from these two devices. So this is kind of what makes it hard to work with data that is of such, like, that is so recent. We don't really know what to make of this. Conjecture one is that there are like two really problematic devices because they got all these reports happening, but it's also consistent with the data that these are just extra responsible manufacturers who are going out of their way to make reports. So we can't actually distinguish whether these are just super bad devices or it could even be the opposite. All we know is that pretty much like all of our events are associated with two product codes in particular. And this is really, I mean, it's for better or for worse, this is like all the adverse events reports that are associated with AIML approved medical devices in the United States to date. So what are these? Sorry, I keep going back, but as you see, you got the PJA and MBW. So I'll try to focus on these in particular to figure out what's happening. So PJA is this device called HeartFlow. HeartFlow is a medical technology company that was established in 2007, which uses coronary physiologic simulation software used in hospitals for diagnosis and management of coronary artery disease. In particular, they use CT scans to create a 3D model of the patient's arteries and calculate a certain mathematical quantity that indicates the extent of coronary artery disease. All MDRs of HeartFlow, of PHA, were reported as false negative results associated with the HeartFlow analysis. So indications of sufficiently high blood flow when a blockage should have been identified. That's kind of the first thing we found. And this is like more qualitative than quantitative. It was just like, let's read all these adverse event reports to see what they say. And pretty much all of them are false negatives. So the system is reporting that there's no coronary artery disease or the level is low when instead it should not be. It is much sort of higher, much more severe. How they're using AI and how, or machine learning, and how that is leading to the particular false negative results is really hard to tell from these reports. Like no such detail is provided in them, and then the company's own technology tends to be proprietary, so we can't kind of reverse engineer what the problem might be. That's already kind of a limit of the reporting system. The source of the error, the reason for the error is also hard to identify. So some of the reports, just when we read them, they attribute the problem to analyst error. So whether it's a system error or an analyst error, it's kind of hard to know. These tend to be pretty short reports. It will be like a paragraph or two. The other source of reports was this NBW product code. So this is a system called the Dario blood glucose monitoring kit. It's a direct-to-consumer device. You would basically connect it to your phone through an app, and it's a glucose level monitor. Most reports involve high blood glucose readings, which are erroneous. So for the Dario system, most of the mistakes are false positives. Often these lead patients to seek additional medical services. So people will get a really high reading, they'll go to their doctor, they'll go to a specialist. It turns out it was mistaken. it's hard to know or to quantify what happens after or to diagnose precisely why the problem occurred, just as with heart flow. So, for example, here's what one kind of report looks like. It says a customer was contacted on numerous occasions to obtain additional details regarding an ER visit and to request their Dario meter back for investigation, and they didn't respond to follow-up attempts. So that's kind of all we see. So, okay, that's the data. That's kind of like what it looks like. That's the extent of and scope of it, and also sort of the limits of how many conclusions we can draw from it. So here's sort of what we think are the big problems in trying to use this to identify any serious malfunctions or product problems with AI/ML devices. Often, when it comes to AI/ML devices, we can have problems without malfunctions as traditionally kind of viewed by the FDA. So traditionally, a product malfunction is an MDR reportable event. As I said, if it results in the failure of the device to perform as intended in a way which could cause, again, death or serious injury. For instance, heart stent fails to operate as supposed to, patient could die imminently. AI/ML products are often probabilistic. Failures do not rise to this sort of level of imminent harm. A few more qualitative examples from this, from the adverse event reports we looked at. So we have things like this. It'll state, as of this date, the user didn't call us back to provide further information. During the call with Dario support, the user's wife refused to give details. Customer was contacted on numerous occasions and did not respond. So it's simply things like this that don't lead to anything like a sort of risk of death or serious injury. The kind of problem, though, it's not necessarily ignorable, but the kinds of problems that are caused by ML devices tend to be small scale, and they tend to create externalities which are then borne by the medical system elsewhere. So even when problems can be identified at the individual level, they wouldn't rise to the level of a reportable event. But if we have a device which produces false positive mistakes which are consistently need to be corrected, as we do with a system like Dario, for example, then this presents a burden of the medical care system as a whole. It's an externality that's not currently borne by manufacturers. In other words, people use the system, they download the app, they pay the manufacturer, and then when they get false positives, they go to their doctor, they go to a specialist, and so forth. At a large scale, the cost adds up on the healthcare system as a whole. But that's not the kind of problem that you identify through individual adverse event reports. So the adverse event reporting system doesn't seem to be particularly useful or effective. Both the quantitative analysis and our qualitative reading of the individual reports suggest that they're not of much use. Typically seems to add little to no understanding to the underlying core issues, and usually there's little to no follow-up and not much done to address a problem, as you saw from some of those write-ups. So what are the big kind of like AI/ML algorithm problems? So there are these kind of like externalities that are not borne by the manufacturer. Glenn and I have written elsewhere with problems that should be identified. So things that have been called by others, not uniquely us, covariate shift, which refers to a situation where the feature distribution changes. This could, for example, happen if the training or early use data is not representative, but it could happen for other reasons as well. A related concept drift refers to a situation where the true joint feature label distribution, in other words, the function we're trying to approximate, slightly changes over time. A particularly important property that we want AI/ML devices to satisfy is something like stability. We want devices to produce similar outputs for similarly situated patients. We can call this like a treat-like cases alike desideratum, as lawyers would call it. In computer science, you might have seen this as the Lipschitz property, which technically requires that for a given distance between two observations in the feature space, their distance should be similarly bounded in the output space. And we want manufacturers to update their products regularly when problems such as the above are identified. So none of these issues are addressed through post hoc case level adverse event reporting. So what should we do instead? One more radical option is to move away from adverse event reporting entirely for AI/ML medical devices, and this also raises a question of whether it's worth defining a unique category for AI/ML devices in particular, because right now they're just bunched up with software devices in general, and traditional software medical devices and AI/ML medical devices are actually quite different from each other. So yeah, option one, should we carve out a unique category and move away from adverse event reporting? Option two, less radical, is there a way to revamp the reporting requirements so as to address salient algorithmic system problems such as the ones I identified in the previous slide more effectively? I'm not sure. This is part of the paper that's incomplete. We're kind of not sure whether to have a more radical conclusion here that like adverse event reporting is just not that effective for AI/ML devices, or that we should have kind of revamped adverse event reporting. Okay. That's it. Thank you all.
Okay, I'm going to chair the discussion for us. So we have 15 minutes or so for questions. We're changing the model, Calvin, sorry.
Oh, okay.
Slight modification in the plan. Yeah, 15 minutes for questions to Boris.
Yep.
PC.
Yeah, just a quick clarification question. So there were so many positives and false negatives. So quantitatively, wouldn't this be sufficient to say that there's something wrong with the device?
Sorry, say that again. So
two questions. First,
yeah.
Clarificatory question.
Okay.
So given that there are so many false positives or false negatives, shouldn't it really suggest something wrong with the device? Secondly, what does a good report looks like for other form of medical devices?
Okay. Yeah. Thanks. So those are both good questions. On the clarification question, it's hard to know whether it suggests something wrong with the devices, just because the reports that we see often tend to be kind of ambiguous and sometimes misleading. So sometimes they're just attributed to user error. So they like use the glucose meter incorrectly, or the operating physician used the heart flow analysis incorrectly. Although just because a manufacturer says it's user error, it's not obvious that like we should believe that it's user error. So it's kind of hard to figure out what the ground truth is on the basis of the reports. The kind of most objective thing that we can identify is like, okay, at least we have like what the problem is, false positive, false negative. That was the first, right. And then your second question was kind of what would be a more concrete problem with other kind of non-AI devices, right?
Yeah, like what would a typical reporting format or content look like?
Right,
Give you kind of information to address the problem.
Yeah, so with things like with kind of like more invasive medical devices, there tends to be more information, like some sort of heart stent or whatever failed. There was an ER visit. There was an attending physician's report. There were subsequent specialist visits. So the reports tend to be more detailed, as opposed to like patient called, didn't respond to further calls for requests for clarification. So they tend to be less ambiguous. There will be kind of like more medical reports that are appended to the initial adverse event. However, the second question is a useful one though, because we are trying to figure out kind of how to frame this project in a way that identifies something that's unique to AI/ML devices, as opposed to problems that might exist with respect to any medical device. And some of these, we're not going to try and establish a complete like uniqueness thesis. Some of these problems do exist elsewhere with non-AI/ML devices, but they seem to be particularly pervasive with them. And a lot of it is just like ambiguity and lack of information.
Okay, got a few people with their hands up. Ready? Let's.
Sorry. Thank you. I'm just curious. Why do people get AI/ML machines?
Why do people?
Yeah, why? I'm sorry. I'll talk you through my idea.
Yeah, go ahead.
So from our point of view, the data actually suggests that they think that it's going to help them make decisions. Clinicians use it simply because it's supposed to assist, and in some cases, in some extremes, they actually think that they're going to replace the clinician. Agreed?
Yes.
So the question then is that if people are actually buying those machines and they think that they don't need the clinician or they don't, or they can manage their problems on their own, does the company that is actually providing that machine have an obligation to teach people how to properly use their equipment?
Oh, do you mean this as a normative question or
Yeah.
a descriptive question? Like, do I think they have an obligation?
From looking at your data, what do you think?
Yeah, well, from kind of looking at the data from the FDA structure, they don't have any such obligation. But if I take your question more normatively, then I sort of agree that in terms of influencing people's decision-making processes, whether it's direct to consumer, kind of like user-centered or facility or physician-centered, on their own, it's not at all obvious that they're improving decision-making or outcomes.
Because your cardiac flow, that was actually quite worrying.
Right.
Yeah, those type of results would have meant, potentially a patient missing a heart attack or ending up with a heart attack.
Right.
And your Dario as well, those guys went into hospital with hypers.
Right. I agree.
Yes. Yeah. So just wondering where the responsibility of the company that's making those devices end or begin.
Right. I mean, now it's almost non-existent. So because most of the focus is on the risk level associated with the device and with the 510K process, particularly whether there's a similar predicate device that's already legally marketed. There isn't really any real obligation on the company to provide kind of real use data or clinical trials in bringing the device to market, because most of them aren't class 3 devices. And yeah, as a normative point, I agree with you that there should be more of such an obligation, and we've tried to argue for that elsewhere. Yeah, thank you.
Okay, and the lady first.
Hi, I just want to clarify the graph that you got, that reportable events actually tapered off during the COVID years from 2020. You got it from the FDA. So is that because they haven't uploaded all the data that we've collected during the COVID pandemic? Because, like for example, in Singapore, we gave oximeters, and oximeters are actually software dependent, but the data collected from the devices may feed into an AI or ML learning program in future.
Oh.
So the data is very key, and oximeters do have some discrepancies regarding like skin color. There is inaccuracies regarding that. So I just want to know.
So it shouldn't be a situation where the FDA hasn't uploaded the data. So that should reflect kind of like the extent of reporting. That was mostly like my own commentary by like kind of like just tracking it to overlapping with COVID. But I don't know why the adverse events drop, because in principle, you may not expect them to, like COVID or not. So I don't know what the reason for that is, but it's not like the FDA hasn't uploaded the data yet. It's not an incompleteness thing. Yeah.
Okay, Abhishek first. Two more people in the queue.
Yeah.
Hey, great talk, Boris.
Thank you.
I've got 3 questions, but maybe I'll just ask 2.
Okay.
Oh, thank you. Yeah, so first one is just more for my curiosity. The 303 cases, those were adverse events reported for AI/ML devices.
Oh, 1 sec. So the 303 were devices. That was the number of devices.
Okay.
But most devices had no adverse event reports.
Okay.
So actually, of the 303, we only end up with 11 that have some kind of adverse event reports. And then the total, I don't think I summed it up, of adverse event reports across those 11 devices is a couple hundred. And then most of those end up being coming from HeartFlow or Dario.
Okay. So this is just for my own curiosity, but how do the ratios of adverse events to devices vary for AI/ML devices versus SAM devices or with other
Okay.
baselines?
Oh, good question. That's worth actually It's worth incorporating into the paper. I don't have it now because it would be the kind of like the complement of those 333, all the SAM that are not AI/ML, and then looking at their adverse event reports. We haven't looked at it, but we'll include that. That's a good point, actually.
Okay. Second question was, there are two types of problems that you've identified, at least that I can tell. The first one is much more specific to AI or machine learning devices, which is that you have adverse events that don't quite rise to the level of death or serious event, and that's fair. The second type of problem is that it's hard to tell whether it's it's hard to tell whether the data is outlier dominated or if there's underreporting going on.
Right.
That seems to be a question that would also be the case even for other SAM devices, or even any sort of like devices or interventions that the FDA conducts analysis on. Are there existing solutions that have been used for non-AI/ML devices, maybe like sort of sampling with serious penalties, that can be used for these devices?
That's a good question as well, and I'm not sure. I'm not sure how significant problems with non-AI/ML SAM have been dealt with, but that's kind of like a good source of that's a good place to look for whether there are any analogous solutions that could be useful. I'm not sure. Thank you. Yeah.
Julian?
Yeah, thanks. That was a great talk. So, I mean, I think it's a great project, so I encourage you to keep going. But in some ways, I think the biggest problem is what you mentioned at the beginning, is that AI/ML is classed as a sort of tier 2 device, not a tier 3 device. Right. So we've done some work showing that because it's not a tier 3 device, you don't do randomised controlled trials. So this stuff just gets on the market without actually any good evidence that it's so. And then you've got the adverse events issue, but surely the bigger problem is that they're not classified as tier 3 medical devices and they're not subjected to randomised controlled trials.
Yeah, I mean, I agree with all this, and it's related to the first two questions, because if you have clinical trials, then you can kind of look at how are actually people like engaging with the device, as opposed to focusing on what the FDA focuses, which is like the submitted report of the device's technical performance, which is like specificity, sensitivity on some often artificial training data set. And that tends to be not that useful in practice. So, I mean, I agree entirely here that, like, yeah, we should move away from that system. But for the sake of this project, we stuck with kind of what exists. It's like, okay, we have these devices, they're basically all class 2 devices, and now we have this entire layer of infrastructure that exists for identifying their problems, and that infrastructure mostly doesn't do all that much. And as a solution, yeah, maybe that's kind of the lesson that we should be pitching. They should have been class 3 devices that required clinical trials before approval. I wonder if that's too radical when it comes to some things that are like user smartphone apps and things like that. Like, it might be too much of a deterrent for ever having something like that on the market, but then you might not want something like that on the market, so you could be okay with that. I might be okay with that. Yeah.
Any further questions? I'll ask a quick one if there's nobody else waiting, but before people think of questions. I'm interested in your options for progressing this forward, Boris. So one thing that really struck me was the variety of different kinds of ways in which adverse errors can happen. So there seems to be an important distinction to be drawn, at least from a sort of learning point, between the machine not doing something correctly and the person using the machine not acting correctly. Mm-hmm. And the intersection between those two things looks really important for understanding an adverse event. Do either of these approaches take seriously the kind of multiple ways in which the human in the loop features? Because it looks like we want to be able to carefully differentiate, whether we're more or less radical, between adverse events which are actually kind of down to the human operator or human being in the machine somehow, or standing in some relationship to it, versus the machine itself or the algorithm breaking down or departing from some way from its normal function. So I wonder whether that's a complication, the human-machine learning relationship that needs to be, in terms of learning from error, that needs to be captured here.
I think, I think it is a layer of complication as you put it, but now that I think through it, it actually, insofar as adverse event reports capture human error, they almost like make the problem worse, because it's like all the reports do is there's some malfunction that's identified, and then the manufacturer says like, well, it wasn't our product, it was user error, and like it doesn't actually help us better understand how to improve decision making with the machine or anything. It's just a way of like deflecting responsibility from the product itself. So I guess this skeptical line of thought leads me to suggest that if we do want to think about how kind of the human-machine interaction actually works in practice, then we really should just do the more radical option and move away from post hoc reporting entirely.
Yeah, I mean, that's right. That seems right to me. It seems like one of the major challenges here is to reconfigure responsibility in the model of reporting.
Right.
Because at the moment, the problem seems to be, that kind of idea of escaping liability or responsibility in that way.
Yeah.
So there's a bigger kind of challenge in the background. Maybe this could help to address in some sense. No.
Right. Like the existing system actually just lends itself to using the human as a scapegoat, as opposed to actually like figuring out how to improve the collaborative decision-making process.
Yeah, exactly.
Thank you.
Okay, we better draw a line under it there. Thanks everybody for their questions.
All right. Thank you all.